The guidelines are basically it's a systematic review and meta-analysis. So in a lot of research circles, this is like the highest level of study where you're actually researching the research studies. You're putting all the best studies together and making one larger study out of them. And it's using a process called the grade method, which is used by a lot of organizations, but it's a very systematic approach to evaluating research. So basically, our group covered, I don't know, 30, 40,000 articles on restless leg syndrome, and several dozen met the inclusion criteria for the analysis, which met that highest level of research threshold. And then it was analyzed together, and the task force was assembled of 7 specialists in this area of restless leg syndrome, mostly neurologists, but some from other fields. And we analyzed this data. This took 5 years. We met at least once a month, sometimes in person, a lot of times through Zoom, but we had assignments between each meeting. So this is a very long process. So it's the 2024 guidelines, but it started in 2019. The biggest thing to understand is that these are the guidelines based on generally the primary treatment of restless leg syndrome as well as periodic limb movement disorder. So this isn't for, 6th or 7th treatment option or very, very complex cases. This is generally should be applied to any clinician, whether it's a neurologist, a primary care doctor, a nurse practitioner in family medicine. Any of these people should be able to look at the guidelines, see a patient with the diagnosis of restless leg syndrome and provide a treatment based on the guidelines. So it's not a law, it's not a requirement. So the drugs that are recommended for don't have to be used. The drugs that are recommended against people aren't banned from using them. So it's important to understand that point. And then the second point is that it's only based on published research. So if there's a drug that someone's using that's not in here, it's not because it doesn't work or it's a bad drug. It's just that there weren't basically randomized controlled trials of the drug. And we make that very clear as we can only comment on what has been published. We're not giving an expert opinion on what we think is the best drug or what we use in our clinical practice. So with that being set forward, the biggest change, this is the most important thing in the guidelines, is the dopaminergic agents are not recommended in the treatment of restless leg syndrome. This was a conditional recommendation, but we have basically gone from the point of, at least with the latest study in 2022, 60% of individuals with restless leg syndrome were being prescribed these drugs. And we do not recommend the drugs in most cases. Why is that? The phenomenon of augmentation, most of the audience should be familiar with this process, but due to changes in the dopaminergic system with long-term use of these drugs, it tends to make the condition worse, almost to the point that it's generally worse than it can naturally occur, the wild type version, so to speak. So you get a condition that is worse than when you first started on the drug. And guess what? It's not 100% reversible if you go off the drug. And even worse than that, it's very hard to get off the drug due to dependence of the central nervous system on the drug. So once you go down this pathway of dopamine medications, dopamine agonists and levodopa specifically, it's hard to get the patient back. You can't, it's not like it just doesn't work and we could just stop the drug. You've now made a newer condition that's iatrogenic. It's much worse than it was before they started the drug, and you can't get them off the drug either. So this is a very serious situation. And that's been the main difference between 2024 and 2012 is that the overwhelming evidence of this process occurring more and more as time goes on, because a lot of these drugs were FDA approved for restless leg syndrome in the early to mid 2000s. Now we've got 20 years of data to show that this process happens every year and it just accumulates over time. So that's the biggest change in the guidelines. I would say the second biggest one is the promotion of iron, the importance of iron. And in the guidelines, outside of the recommended treatments, we have what's called a good practice statement. And the good practice statement is that one of the key points is that iron is so important to the pathophysiology of this condition, the low brain iron levels, poor iron metabolism in the central nervous system. It's so fundamental that individuals with restless leg syndrome should be tested regularly for their serum iron levels. So ferritin and iron and total iron binding capacity, which is also called the iron saturation, transferrin saturation. These should be done in the morning while fasting overnight. And uh, in this situation that a lot of the individuals who have had restless legs for a long time, they may go without any knowledge of their iron levels. They may be persistently iron deficient and no one knows about it. And the second point, other than the fact that they should be monitored for iron, is that the iron levels for those with restless leg syndrome are not the reference ranges that you see in the lab, which are based on the population of the people, percentile-based population. There is a clear threshold. The threshold, however, it's not based on studies of, well, what threshold relates to what change in the condition. So there's been no testing of these gradations of what iron levels are the cutoffs. So we generally say that individuals with restless leg syndrome should have a ferritin level above 100 and a transferrin saturation above 20%. And so either of those is low. They may benefit from either oral iron or intravenous iron, and those would be the two main treatments. So with that in mind, the new treatment that's strongly recommended is ferric carboxymaltose. It's one of the higher strength, high iron binding forms of iron. It's a slow release form of iron. So it's very well, it binds very well to H-ferritin, and H-ferritin we think penetrates the central nervous system and may be highly involved in restless leg syndrome. So ferric carboxymaltose has been the most well-studied in restless leg syndrome, so it obtained a strong recommendation. But ones that we use very, very commonly, low molecular weight iron dextran and ferumoxytol, also received conditional recommendations for, and only because there's just less research on those drugs, but it's thought that these drugs, these big three drugs, and there's another one called ferric derisomaltose, which is even newer, but hasn't really been studied in this condition. So those four drugs really are going to be the backbone of treatment, particularly in those who have low or low normal iron levels for restless leg syndrome. The other major group of strongly recommended treatments are the alpha-2 delta ligands. Those we all commonly use for neuropathic pain now, maybe in the past for epilepsy, but mostly neuropathic pain. These include gabapentin, enacarbil, and pregabalin. All three of these have strong benefits in terms of randomized clinical trial results, and they outweigh any of the adverse effects with these drug classes in most cases. And as I forgot to mention at the beginning, the great criteria ultimately, when you're looking at a treatment, you're looking at the difference between benefit and risk. And so it's really the benefit of the drug versus the risk. So are the alpha-2 delta ligands or iron infusion the most powerful treatment? Maybe not, but they're the ones that have the most separation between risk and benefit. And that's why they have obtained the strongest level of recommendation based on the randomized clinical trials, mostly with these treatments.